Hi, I'm Dr. Howard Zucker, the doc in Docology. You may have seen the headlines lately about the federal government canceling $11 billion in funding to the states for COVID-19 preparedness and response. That's 11 billion with a B. Now, 23 states and the District of Columbia are suing to get the money reinstated. But if the Trump administration prevails, what will that mean for your health and your family's health? And that's where we're here investigating to get today with someone who knows these issues inside and out. And that's my old friend, Michael Fraser. Now, Mike spent over 7.5 years as the CEO of the Association of State and Territorial Health Officials, or better known as ASTO. And what do? They help the state health officers across the country collaborate in fighting disease threats. So we worked together when I was the New York State Health Commissioner, and I am so pleased to have him join us here on Docology. Mike, great to see you, and welcome to the podcast.
Thanks so much. It's great to be here. Good to see you again. We've
been
through a lot together.
We sure have, and the pandemic and many other things. I thought what we could do is start with the biggest question of all. Do these $11 billion cuts that they have pose a threat to America's health? And if they do, what can we do about this?
Yeah, you bet. I mean, they certainly don't help. Let's put it that way. But yeah, I mean, I think when you look at the programs that have been cut and the programs that states are fighting back for, there's a reason. There's a reason. They know that those programs contribute a great deal to the nation's health. And HIV prevention, overdose prevention, injuries. There's a lot that could potentially be impacted by a lack of resources in the states when these dollars go away.
It seems crazy. It really does seem crazy. And I'm curious, is when these dollars disappear, how does that affect like the kid in the south side of Chicago, or the grandmother who's in assisted living in Tulsa, Oklahoma? Like, how does it affect them on a personal level?
Yeah, I mean, we've got, it can get very complicated very quickly, and we talk about systems and state-federal relationships. But at the end of the day, someone in every community, someone in every state is making sure that individuals in places have access to clean food, clean water, clean air, live in conditions that are safe. And when those programs go away, there's fewer inspectors, there's fewer resources. You're putting people at risk.
Right.
And certainly, a lot of the core services that public health does, vaccination, immunization, prevention, save money. That old saying, pound of prevention is worth a penny for cure. Other way around.
Other way around.
Other way around.
We get it.
We'll get it one day. It's only been 25 years that I've been doing this. There's a reason for that. And I think, we will start seeing more bad outcomes for people. We will see more illness. We will see things that we haven't seen before in the U.S. in any scale, like measles.
Sorry. So go ahead. So what you're saying is this is really personal. This really hits an individual. It's not this bureaucratic issue or just a big picture issue. It's really right down in the ways that people can live their lives and their health. I thought maybe what we could do, since a lot of people don't recognize this, is talk a little bit about how the federal government and how the states work together and how the money flows into public health and then where it goes a little bit. I mean, you spent your life doing this, so maybe you could share a little bit about that.
Well, I think this is a great opportunity, and we could talk for hours on this one, because this is a whole study in federalism that we can talk about. But basically, first, folks have to remember there's a reason why states get funding to do this. They don't have the money to do it themselves. Okay. Right. So the need is there. The federal government, through its process, through Congress, appropriates to the states for things like public health and prevention programs, because the states are strapped. And what's the big difference between the states and the federal government? The states have to balance their budgets. The federal government doesn't. The federal government can run a deficit. And that's where we start to see a lot of these problems becoming federal problems that are actually state problems. And so states receive grants from the federal government to run an array of services that many folks are only just learning about now, from keeping their Social Security office open all the way down to the public health programs we're going to talk about today. And the federal government through Congress appropriates those to the federal agencies, the departments and the agencies, CDC, part of HRSA, part of HHS. So when those programs get cut federally, and it sounds like we're cutting CDC, many of those dollars are passed through to states. In fact, the most recent analysis that I remember seeing at ASTHO, I left there a year ago, was that about 70% of those dollars flow out of CDC into state health departments and by extension into county and city health departments. So when you cut federally, you are cutting locally in most cases. Now, I also think it's really important for folks to remember that publicly financed healthcare is not the same as public health, the kind of public health programs that I'm talking about right now. We've got Medicaid, which is a state-federal partnership. There are proposals to cut that, but I'm really focused on the public health and prevention work. There's also Medicare, which is federal dollars for healthcare. So you could say that's publicly financed healthcare. And there's also the VA, which is a huge national system that provides benefits to veterans and their families. That's publicly financed healthcare. Public health are those things that help communities stay healthy. And in many places, they use those dollars for clinical services like vaccination. But in a lot of places, they use them for public health population-based programs, which many of us don't even know exist and we'll start seeing now. You know, you shouldn't have to worry about whether the food on that shelf or the pizza you just ordered has been delivered safely and in a restaurant that you feel safe eating in. And as states have to cut back and have those cuts get translated locally, there's going to be fewer folks to assure that those things are happening, just at a very basic level.
So you're basically saying that the states are going to have a fever, they're going to get sick. And so how do they recoup these losses then? So if the money's not going to come in from the federal government, what do they do?
Well, the solution to that is the $11 billion question, but I'm pretty sure they're not going to raise taxes. However, where else are you going to raise those dollars in the government? So I think we could probably all agree, and I've worked with government for 25 years, federally and through these different roles with public health, that there are inefficiencies and there's things that probably could be consolidated. And I see the argument there, but the scale that we're talking about here and the real focus of a lot of these programs, those are things that states will never be able to come up with the dollars. So, I mean, there was very few states that had a surplus, and probably after what's happening economically now, there will be no state with surplus. And so there's no extra money in the system. And when there is, it generally goes to publicly financed healthcare and mandatory programs that have to be provided, not some of the things we're talking about, which are the public health programs that get funded year after year.
So I just want to move on something you just mentioned about you sort of see why they're saying some of these things, but let's just go down the path of what they may be thinking. Like they're saying the pandemic's over, no need to spend the money. Are they wrong about that? And if they're wrong, then why are they doing it?
Yeah, well, the pandemic is over. I think we've officially declared that, although I know lots of friends who still keep telling me they're getting something. But I do think it's over. And certainly that's great news. I mean, we were able to do a lot of things we weren't able to do before. But there's going to be another one. And if we learned anything in COVID, it was that boom and bust cycle of funding public health created a real lag for us to start responding effectively. So a lot of what they call COVID programs today, and say, well, why would you need that? That was to build that infrastructure, to build that capacity for the future, so that when something does happen, we see it more quickly, we have the resources to respond to it, and we can control it more effectively. Right. And so they may have been COVID dollars, but they were being used for a host of improvements to our public health system, including people, including systems, including new ways of looking for disease and disease detectives that are gone now. And so certainly the next big thing, and we're seeing a mini version of this with measles, is going to tax a system that won't have the resources it needs to control it. And we will see more illness.
Well, we've seen that in Texas, right? Texas has said that they cut back, HHS cut back $900 million in grants to their department that deals with epidemiology and lab support, and they've canceled 50 upcoming immunization clinics. So it sounds what you're telling me is that without this money, even though the pandemic is over or quote unquote over, there are other things that are going to happen, and the money is not going to be available to tackle that, and that will impact everyone's life, right down to the kid who's in school who needs an immunization, to the person who's just trying to manage their day-to-day healthcare.
Exactly. And, big state like Texas had a lot of resources, but you can imagine in some of these states, and again, pulling some of the numbers when I was at ASTA, we had states that almost their entire state health department budget was federally funded. Now, we can argue whether that's the responsible way to do this or not, and there's plenty of time to argue that. But the real issue is the need was there, and they funded those programs, and moving those out is just going to decimate any of the activity that was public health was supporting. So, yeah, I mean, and, this is going to have impact on our neighbors, if not us directly. I like to be able to get on an airplane and know I'm not going to get measles. I like to take kids to Disney World and know that I'm not exposing them needlessly to a disease that's preventable. So when these things happen in states, it has a profound impact. And what's made worse is when they happen regionally, because a lot of what the CDC assets and capabilities supported were interstate conversations and capacity. No state can respond to a multi-state outbreak, but for lots of different reasons, people, policy, all those reasons. It's why when there's a big hurricane that affects a huge swath of the country, we have to send federal resource there. There's just not enough locally. And we can imagine that's going to happen more with some of these outbreaks potentially.
Well, I always felt that that's the role of the federal government. When we have major crises, they're supposed to be available to help out. I mean, you bring up this issue about the airplane. I was just sitting here thinking about that. Right. The next thing you know, this disease, this measles issue, which is in states across the country now, it could just become one enormous challenge. I wanted to have you talk a little bit about what.
And that's just measles. Let's just, I mean, that's preventable. We have a vaccine for that. It's pretty well understood. But let's talk about one case of Ebola.
Oh, I that's a great. I would love to talk about that because I remember that one case of Ebola, like when we dealt with it. The panic that can occur, right? And I was going to bring that up, Ebola, and the next thing you know, you could shut down the entire, way the country operates as a result.
Absolutely, and a lot of the strategy there was to invest overseas in those countries where we know Ebola is going to start.
But we're not doing it anymore.
Now we can't do that anymore. So, I mean, I think we all need to ask ourselves this question: why? And well, again, I can understand, and certainly I'm centrist. I don't want to take a political point of view. People ask what party I'm in. I'm the party of health. Let's do things that keep people healthy. I don't care whether that's red, blue, purple, whatever. But I mean, there's some common sense to these investments. Now, again, could they be managed more efficiently? Could we have 5 agencies instead of 1? Are there ways to realize, some of the bureaucracy, getting that back to a maybe a more manageable resource? Sure. But let's not cut the EIS program, the Epidemic Intelligence Service. Let's not close strategic offices of the Centers for Disease Control overseas. That you know what those guys do. They're the early warning signal. That would be like taking out all of our radar and just waiting for some missile to come into U.S. airspace. Why would you do that? Why would you do that with something like Ebola? It's hard to understand and to do it so quickly. And I think we do have to remember these are people.
Right.
So they've given their lives to CDC, to public health, to many of their agencies. HHS agencies include FDA, CDC, HRSA, Agency for Healthcare Quality. There's just a lot of places where there was a reason why they had 80,000 people. There's a lot of work there.
I mean, it's the people who work there, but it's also the people in the country, right?
Absolutely.
And so you bring up the issue of like not having our radar systems in place for sort of that kind of attack, but it's the same thing as you just mentioned. It's the radar systems to make sure we don't have some disease that comes in, whether it's Ebola or something else. We had the same thing with Zika. I'm curious, have you I reached out to a couple of the health commissioners and I'm waiting to hear back from them. Have you been in touch with some of them? Because I could tell you, I remember when we had Zika, Ebola, all of those, we were working together during that. And I was on the phone with you. It's like, hey, Mike, what's the story here? You know what I mean? What's going on in Capitol Hill? Fill me in.
Yeah.
Are they reaching out to you? Because even though you're not in the job anymore, are they reaching out anyway?
Well, they're reaching out to each other. I know that's the first thing health officials do, because they support each other and they want to, that network that asks those supports is so critical, And what's interesting is I have not heard a lot, but I've seen a lot more online. I've seen a lot more health commissioners posting the impact of these cuts on LinkedIn in real tangible ways. It was very difficult, years ago to get folks to talk about what this meant. They would say, well, we'd lose a planning committee, or we wouldn't have we'd have 4 staff instead of 5. But the stories that I'm hearing now, like you said, about the kid in South Chicago or the grandmother, and that they're really able to tell that story now in a different way. And I think they're telling that for lots of different reasons. What's also different with health officials today, and I saw this as I was leaving ASTHO, but several years leading up to that, in the pandemic and afterwards, was that the role of a state health officer has become so much more political. It's always political, but so much more partisan.
Yeah.
And that I was really worried about, to be honest, because there are some things that we all know to be true. Vaccinations work. We've got a lot of good data there that many of these folks aren't going to say anymore. And so these roles have become much more partisan, unfortunately, when it really should be about the science.
Do you have some examples? I'm curious as to what you've heard. You don't have to tell the state or anything, just in general. Have you heard some examples about some of this partisanship or some of these challenges that they're facing?
Yeah, well, I mean, I think there's been there's been a lot of, look at a state where we have an outbreak right now, right? Measles. And I mean, certainly there's been a push, but a lot of that's been local.
Right.
So I think state health officers have to walk a very fine line, right? And they're really relying on other partners, physicians in the community, hospitals or health systems, instead of what normally would come out of the health department for that very reason.
Right. I mean, that was the challenge in New York State. It was always like, okay, we have a crisis, then you presented the facts to whoever the elected official is and say, here's what the best science is telling me. Right. And
I mean, I don't know. It shouldn't feel nostalgic to say that's the way it is, but it does in some places now. Right. I mean, we've had a lot of change. I mean, I never thought I would see the day when folks took fluoride out of the water. And
I know. Scary.
Or recommended not getting vaccinated for a disease that we know can be prevented with a vaccine. So it's a very strange place to be. And this is on top of the cuts, which just sort of create all this uncertainty and a lot of misinformation. So a lot of what we relied on public health departments to do was give us those facts and to share the situational awareness and analysis. And they can't do that anymore. A lot of those data systems were closed off or shut down.
I mean, you know this so well. You've lived the world of Washington. I'm sure it probably makes you feel terrible. So I was curious, like, how do you feel about what's happening, and where do you think we'll be in 2 years from now? I mean, just take 2 years.
It feels horrible. I mean, there's a personal toll to this because a lot of those folks and those names in the articles are folks I know and agencies I work with really closely. There's a professional sadness because, I mean, a lot of the work during COVID and prior, a lot of that advocacy was really, ASTHO was championing that with our members, with other partners, and to see that all just go away in one fell swoop is real disappointing. So, I think the pendulum has to swing back. I mean, how many kids need to die of measles before we decide that was a bad idea? I mean, how many new viruses have to emerge that we have no understanding of their transmission or epidemiology? I hope zero. I hope in 2 years I can say, we've all been healthy, but I don't think that's going to be the case.
Right. And
how many more kids are going to start smoking? Why? Right.
Right.
And that shouldn't be a partisan statement. It really shouldn't. And here we are. And that's, I think, extremely unfortunate.
So it goes back to that kid. Sorry, go ahead.
Yeah,
sorry.
Please.
Yeah. No, I was just going to say, it goes back to that kid in the south side of Chicago, like, whose life is really impacted because of the cuts. And also, how many people are going to quit their job and never come back to federal government or into public service, which is what we need. We need those young, energetic people to say, I'm going to do this for the better cause.
Yeah, that's a really important point. The post-COVID, the schools of public health enrollment skyrocketed. People really wanted, they got a new awareness and appreciation for what public health does, and they wanted to get involved. Lots of folks enrolled in public health programs. We had a workforce challenge in public health prior. I mean, I don't, you know, if you look at the average salaries of a state health department employee, you're not going to be impressed. We're not talking about gilding, you know, anybody's pockets with that. So these really are people doing the work because it matters, mission-driven people. And so it was hard enough to recruit in public health departments. And post-COVID, a lot of people left, retired, burnout, 3 years, plenty. I don't want to deal with this anymore. And I don't blame them, honestly. But we had a workforce shortage and an inability to really attract a lot of new talent to public health then. Now, all those programs are gone. And then you got the double whammy of a lot of the research funding that was going out through NIH to universities, supported a lot of those trainees and, you know, again, supported a lot of those faculty in those institutions. Again, there's a reason why all these dollars were spent. So to take them away, it's gonna have just a tremendous deleterious effect on public health practice, investment, well into the future. And I think, you know, I've heard the line, well, if it's that important, private industry will pick it up. I have yet to meet anybody who's making a lot of money in public health on the commercial side. So, you know, I think that maybe there'll be some great innovation technologically, but there's some pretty basic shoe leather, walking in a community and doing the public health work that you cannot replace that way. And there's a role government plays, and this is a big one of them.
You've said it perfectly. That's exactly right. There's a role for the United States government to do things to make sure Americans are safe and healthy. And this is a concern with these $11 billion, but it has been challenged in the courts. So it is possible that, you know,
it is possible. And, you know, there is the opportunity to say this isn't the way we do it. I would agree. I mean, if Congress wants to make different decisions, we elect those folks, and that's the way it works. But this sort of unilateral cut, and you know, again, I think it needs to be a debate. It needs to be a debate, not a unilateral decision. And people need to be accountable for those decisions. And if we all agree with them and we elect the people that'll do that, I don't think anybody knew this was going to get like this.
Yeah, I know. A little scary. What would be like your 3 takeaways if you were sort of saying, here's what you need to know, America, these are the 3 things?
I mean, the work matters. I know we have this public perception of bureaucrat, technocrat folks sort of gaming the system and, you know, showing up and then going to Home Depot for the rest of the day. I mean, that's the narrative some people have about government employees, or they're totally inept and inefficient. I have yet to meet anybody in any state health department that fits that description.
I know.
These are lives, and they're our lives too. I mean, because we benefit from these programs. So the work matters. I would say that we need public health. How we fund it, definitely subject to debate, but we need it. And so to eliminate it and to know that means those programs are going to end because the states won't pick it up is pretty significant. I would say continue to focus on the science. We have to use data to make decisions. And when we debate what the public health system should look like coming out of all of this, there's going to be some things we know, and we need to hold true to those, you know, or again, we won't be helping ourselves. And I think there is an opportunity to have a conversation about efficiencies and how government can be more effective. Everybody wants that. I pay taxes. I want that. I don't want to waste the money that I pay in taxes. Nobody does. But we need a longer runway to have that conversation than the first 100 days of somebody's administration. And so I would hold on to those 3 things.
Got it. This is great. You know, Mike, I could talk to you for another 2 hours, and maybe we'll sit down. I'll come out to Chicago, sit down, and you know, a deep dish pizza, right? Because that's Chicago's most famous.
I don't know. That's not healthy. You know,
I know it's not healthy, and I know I said that. I was thinking about that, but you know, if Giordano's is still there, I don't even know.
It's still there. They're everywhere. I'll have a salad.
I'll come out. Yeah. I used to live in Chicago. I'll come out there. I'll sit down for a big pizza and go through some of these topics and just hash it out, and maybe we'll come up with a solution or so. But we have to go to our most important guest, which is our subscribers. And so I want them to have a chance to share, for us to hear their questions and to share some of their thoughts. And so we're going to tee that up. Kat's going to work on that now. I do like to always mention that the podcast is for informational purposes. If someone has a medical question, they really should see their doctor because they know your medical history. But Kat, let's pull on the first Docology caller now and see what they'd like to ask Mike about.
Well, I always kick off this segment.
Yes, that's right, Kat. I forgot about that.
So I always give folks an opportunity to drop their questions. But you had mentioned sort of like a potential pendulum swing, hopefully, and back in a different direction. And I was wondering, in your estimation, sort of like what's possible for states to do and what can or are they doing while there is this sort of inadequate federal support in terms of the funding in the event that it doesn't swing back anytime soon?
Well, I think one of the things I know about public health professionals, and this is why it's been so hard to talk about the impact of cuts in the past, is that they're going to rise to the occasion and burn themselves out working 16 hours a day, 7 days a week. So but this is so big that I don't think anybody's gonna be able to make up the slack that way. So really, again, what we would see, and I'm assuming is happening now, is folks prioritizing what's the most important thing we need to do. There's a lot of states that have a public health system that's very decentralized. So every county, every city has its own local health department. There's a lot of resources that are spread, especially in states that have strong home rule, township or village or municipal agencies. I think we're going to start to see a lot of forced consolidation to realize some efficiencies there and pool resources. And otherwise, flush times, you may not have them. Maybe that's a good thing. I don't know. I don't know, have the data on that. But I think we'll see folks consolidating as we would expect to use resources more efficiently. And like I said, that's a good thing, ultimately. I think, I haven't heard any governors say they're going to start raising taxes to make up for the difference. So that doesn't really seem to be an option. And I think folks are going to prioritize. And then we're going to look to the healthcare sector, which traditionally hasn't really been all that concerned about prevention. We're going to look at insurance companies and healthcare facilities that may be able to provide some of the services that a health department might have otherwise. Someone's going to have to pay for those. So we'll see premiums go up. Maybe, again, we'll see expectations of the Medicare program and the Medicaid program go up. So it all, you balloon, you squeeze, it's all going to go somewhere else. And I know that health departments have always looked for partnership, and this will just, again, push that opportunity. I think within states, there's a lot of different local assets. There's foundations, there's other opportunities. There's wealthy folks who may start an interest in public health after all this. But again, the magnitude of what we're talking about here is pretty breathtaking when you think about how to support a public health system where you lose this level of investment.
I mean, you worked closely with the local health department teams as well, right? Because there's the ASTO, but there are the other organizations as well. And I'm sure they're probably feeling this just as much as the state health commissioners are.
Definitely. And especially, some of the big cities are bigger than some of our states,
right.
In terms of the asset they had and the functionality that they had and the expertise that they had. And they've spent a long time deduplicating that and making sure the lanes are, clear between what the state does and what the locals do. But I think we'll see more of that.
What could we tell some of these graduating public health students who, sort of say, I don't know what to do about a job? I mean, I want to make sure we keep them energized. Is there something
we got to keep them energized? You may not be doing what you thought you're going to be doing, but it's not like we're seeing a lot of people wandering around.
That's true.
I get in these fights with, there's plenty of sick people, unfortunately, right?
Yeah.
And so I think taking a mindset that, you may work in a setting that wasn't where you thought you would be, but you can still do the work. The work is still there. What I don't want to see is a brain drain with folks that move into other discipline, move overseas to do work. We know that's happening already with some of the research function, and lack of funding for research here will lead other countries to get that advantage because they're willing to invest in research. Right. So we'll see, but I would say stick with it. If you come up with a great new technology, I'm sure there'll be opportunity there. we started to see through the pandemic a lot of health insurers and hospitals doing more in public health and prevention. So maybe there'll be opportunity there. But like I said, that still needs to get paid for.
We'll see where we are with that. Yeah. America, everyone came to the United States for medicine, public health, right? To learn, and then they'd go back to their country taking the knowledge they learned here. Right. It would be so shocking if people in the United States start to say, well, I'll learn that, I'll take my research, I'll go elsewhere, or I'll go elsewhere and get my research done there. Kat, who else do we have up?
Gonna bring up Mr. Joe here. He's got a question.
Hi, Joe. Great.
Hi there.
How are you doing?
Doing well. Hey, I've got a question. So I live in Texas. My dad is a Vietnam War veteran, has been a really major beneficiary of the VA system. He had a quadruple bypass about 10 years ago, and has really greatly benefited from the VA health system. And so I've kind of two questions. One, how might these cuts affect his care, his routine care, and his managing care as he, continues to go on throughout his life? And then my second question is, some of these major procedures and things like that that the VA provides are actually outsourced to other doctors and other hospital systems. So how might these cuts affect their ability to do that, or would even more services be outsourced to other specialists and other doctors in other health systems outside the VA?
Sure. I'm not an expert on the VA. That's a different administration from HHS, but I do know VA well. And we're tracking the VA in my current role because we do provide a lot of support to the laboratories and the pathologists that work for the VA. And what I've heard over the last few weeks is the cuts at the VA have not been specifically to healthcare providers, but more on the administrative side, procurements and all of the folks that are in contracting. So what I would imagine, and again, I don't anecdotally even have any data to support this, but what I imagine would happen is the care will still be provided, but it'll probably take even longer to access. It may take longer to make an appointment. It may take longer to deal with some administrative issues that might get complicated. In terms of, so that's minimally what I think we would experience. I know we're hearing that in Social Security for the same reason, and probably some other agencies. In terms of impacting the private market, and the reason why VA did that was because the need was so great. They had to kind of have a pressure release valve to send folks to someone else because they couldn't treat everybody in a VA facility. Those places potentially could get busier, I would assume. A lot of those places have different copays and costs associated with them, which is why they weren't in network to begin with. So we may see, again, individuals having to pay more. I don't know. I think, again, what that remains to be seen, but I don't know, Howard, what do you think?
No, I think that's a good point. I also think about what's going to happen if they cut back, and what if they start to cut back some of the VA hospitals. I mean, the VA system is an amazing system of healthcare delivery. And plus, from the standpoint of just science, a lot of information is gathered about patients in the sense of because their records are sort of much more you're able to track it a little bit better, so you can figure out about long-term effects of diseases, which is helpful for everybody. But what if they start cutting back on some of that? It makes me think, between what you asked, Joe, and Mike's answer, what is the big plan here? You could say, well, I'm going to cut back on this, or I'm going to cut back on the VA or HHS, but what's the plan? I mean, that's what I was wondering. I was going to ask Mike, 2 years down the road, is there a plan? Is there a blueprint? I mean, you don't build a house and not have a blueprint. So what's the blueprint?
Well, no one sent me the plan. Let me put it that way. I would like to think there was some foresight into the impact of all of this. I think, broadly speaking, folks who believe the government is bloated and that there's a lot of waste, there's fraud, that those dollars could be used more for actual services, which we all would agree with. But I think, again, in the programs that I'm aware of, especially the programs we're talking about at CDC and HRSA, they were delivering essential service. I don't really even know what fraud would look like in one of those settings. So I think the general plan was scale back the federal workforce, ultimately help reduce the deficit, which there is one. I'm not going to deny that. And continuing to spend is not good for us over in the long term. But I think that in other industries, there is the opportunity maybe to privatize and, get capital investment and venture capital involved. And we even see that in healthcare. But in public health, like I said before, I don't think anyone's opening a business in restaurant inspecting. And if they do, it's going to be a hell of a lot more expensive than it would have been in the public sector, most likely. So I think that it might have been misapplied in this case, that thinking. But I think ultimately the plan was to shrink government, which, what I've seen when folks have, and I've worked in this space for 25 years, when candidates of both parties have said they're going to downsize or shrink government, what happens is the direct full-time equivalent count in a government agency does go down and is capped, but the dollars spent in contractors and outside services goes up, and that's usually more expensive.
Right.
So the cost savings never really realized. Now maybe in this case the money will go away. Maybe Congress will decide, we'll just not appropriate to that. But the money's still there. The people are gone, but the money's still there. Right. And so we're kind of in an interesting predicament. And what most importantly will be interesting to see what happens in the next election cycle, the impact of all of this.
Midterms,
right? And that's a year plus away. Yeah. But folks are already talking about it now.
Yeah, right. Thank you. Joe, I'm curious, did you ever talk to your dad about this a little bit?
Yeah, some of the stuff that he's mentioned is whenever he goes into the VA, he sees that there is a lot of amazing doctors that are there and doing incredible work. Probably doctors he never would have thought to go and see before, but he also admittedly sees a lot of waste and at times loitering, just within the hospital. And so it's this kind of juggling act of, what's the best direction to think? Is it, do we need to cut that waste? But is it administrative, as you mentioned, or is it on the care itself? It's a very fine line to balance, but I can also tell you when he goes in for things like major procedures, and he was I mentioned a Vietnam War vet,
right?
Which many of those are experiencing great effects from exposure to Agent Orange, and so because of that, he's had lifelong health difficulties of that. Jumping out of airplanes crushes your spine, and so he's had stenosis and all sorts of major issues. A lot of those things have also been kind of outsourced. You go into the VA, you get your initial consult, and then you go out and they say, okay, well, go visit this specialist at this particular place. And so from that perspective, it's the system is working really well for him. Because he's able to get the absolute best care that he can as possible. But we also want to make sure that continues to be the case.
I think at some point it would be really great for one of our podcasts to talk about the issues with veterans and healthcare and some of the things that you just raised, Joe, about the access to healthcare that they need when it's more of a subspecialty issue, but also just in general, some of the long-term effects of some of the challenges that they may have experienced with the Vietnam War, other wars as well. But thank you, Joe. Thanks.
Yeah, of course.
Kat, what's up?
I almost talked on mute again. So we got a shy group here today, but I'm going to bring up John, and he's going to be our last audience question.
Okay, great.
For today.
John, what do we have?
Hi there. Is it Dr. Fraser or Mr. Fraser?
You can call me Mike, but
he's
just
like a doctor.
PhD. I'm not a physician.
Well, PhD. That's okay.
I leave the medicine to folks like Dr. Zucker here.
I'm going to call you doctor anyway.
Thank you.
You mentioned that some states receive 100% of their annual health funding from the federal government. Which states are those? And in general, which states are at the gravest danger soonest?
Close to 100%. I think there's always some state match requirement, but I mean, there's some states that I remember being around 90%. I don't want to get it wrong. So what I would suggest, and this is all public, is go to the astho.org website, and they have a profile of state and territorial health departments. And the most recent one will list that investment by state. and you'll see what percentage it is of this overall budget for the state health department. And the Trust for America's Health, which is a nonprofit and nonpartisan think tank for public health, has a report on funding public health annually. And that's probably the most recent that would have the per capita investment in public health, as well as the overall state investment in public health. The states, what I've seen in my experience has been in the Southeast in particular, the states in the Southeast, they're small population states for the most part. Their health outcomes in general are pretty poor, along with a lot of other outcomes like education, overall income. Because the states are poor, there's not a lot of investment in those states. And a lot of the dollars that they've used that they do have at the state level is for publicly financed healthcare. So they're delivering clinical services to folks who are uninsured and need basic healthcare. And there's not a lot left over for the work of public health and prevention. And so those are the states that really relied heavily on federal investment. So I would just take a look at that. That's just some of the themes that I've observed. But to get the most current list, you can get those in those two sources.
And those are two great websites to address this. John, anything else?
No, thank you.
That's good.
Thank you. Great question.
Well, thank you, Mike.
Where do you live, John?
New York.
Okay, well, that's not one of the states.
Good point. We worked hard with getting funding, and our legislature, New York State legislature, is always interested in the public health issues. But and we have a great lab up here in New York, but not the
world-class lab in New York.
Wadsworth is a great lab, I know, so that's a pleasure to have that kind of facility in our state, in New York, I should say, but not the case all across the country. Mike, it has been wonderful to speak with you.
Thank you.
Hear your views. It's scary. Some of the thoughts are really scary with all the changes that are occurring in Washington. But what you shared about how the states are affected across the nation as a result of these changes is helpful for everyone to hear. And I hope that those who are making some of these decisions also hear about the challenges and what we're concerned about. So I look forward to, you can come back anytime you want. I look forward to talking to you further about this and other issues. That is our show for today. Next on Docology, we're going to hear about the global health threats with Dr. Ian Lipkin. He is a virus hunter. He's the director of the Center for Infection and Immunity at Columbia University, and many different issues that not just happen in the United States, but around the world that affect the people here in the United States. So remember, if you are a Docology subscriber, you can join the show. You can ask your questions to our guest, to me as well. Just all you have to do is click on the link in the bio. So I will say, tune in next time, because the topic we cover may just save your life. Docology is a production of Hang Media. Our producer is Catherine Warren. Ronnie Selig is editorial advisor. Our creative director is Anna Richard. Janine Wilson of Wilson Media Group handles paid marketing. Our publicists are Leslie Ann Wade and Jerry Caracoli. Theme music was composed by Nick Kitts. Subscribe and join our community at docology.life. Until next time, move, wash your hands, and stay healthy.